Quote, "When I was initially diagnosed, fertility didn't really enter my head. It was later that the doctor advised me the treatment might affect my ability to have children," unquote.
Wow. Yeah, that's heavy.
Right.
Yeah.
That quote actually comes from a patient named Robert, right after he was diagnosed with Hodgkin lymphoma. And
Mhm.
I feel like it perfectly captures that secondary shock wave of a major medical diagnosis.
Oh, totally. You're just bracing for this immediate fight for your life, and then suddenly
Suddenly you're told the exact cure that might save you
Mm.
could also, permanently erase your future family.
Yeah, it is a profound whiplash for patients. You're presented with these highly effective, life-saving treatments, but, well, the tragedy of oncology is that treatments like chemotherapy and pelvic radiation they're inherently indiscriminate.
Right. They don't just target the bad stuff.
Exactly. They don't just target the malignancy, they can permanently alter your body's reproductive capacity.
And that is exactly what we're focusing on today. So, welcome everyone to this deep dive. Whether you are prepping to support a loved one through a medical journey or, just catching up on clinical practices, or you just love learning how medical science tackles complex human problems, you are in the right place.
Glad to be here for this one. It's an incredible topic.
It really is. We are looking at the medical toolkit designed to stop that reproductive collateral damage from happening. We're pulling from clinical practice guidelines from the American Society for Reproductive Medicine, systematic reviews from Cochrane, patient data from Macmillan Cancer Support, and several highly detailed surgical case studies.
It's a really robust stack of sources.
Yeah, and the mission here is to understand the established and experimental options available to preserve fertility before a patient undergoes these gonadotoxic treatments. Basically, treatments that induce premature ovarian failure or medical menopause.
Right. And to really understand how these protective interventions work, you have to look at the biological target.
The ovaries.
Right. The female reproductive system relies on this finite reserve of primordial follicles, which are nestled deep inside the ovaries. And what's fascinating here is that modern medicine has basically developed this multi-tiered toolkit to protect them. Because these follicles, they're the dormant precursors to mature eggs.
Okay, so why do the cancer treatments specifically hurt them so much?
Well, the problem with gonadotoxic treatments is their mechanism of action. Chemotherapy agents, particularly alkylating agents, are designed to attack rapidly dividing cells or, to just shred active DNA.
Oh, I see.
Yeah, and because the delicate primordial follicles are constantly undergoing this low-level cellular maintenance, they just get caught in the crossfire. The whole reserve gets wiped out.
Wow. But modern reproductive medicine has engineered some pretty wild ways to bypass that, right? I mean, reading through these clinical guidelines, it seems like the interventions fall into a few distinct categories, mostly depending on how much time you have.
That is the crucial factor. Time.
Right, because if a patient actually has a biological runway, say a window of a few weeks before treatment absolutely has to start, the standard protocol is essentially to harvest and freeze the cells beforehand.
Yeah.
Okay, let's unpack this. How does that actually work?
So if time allows, the gold standard is the cryopreservation of mature eggs or fertilized embryos. But like you said, you hit the key word, runway, because this pass requires controlled ovarian stimulation.
Which takes time.
Exactly. The patient needs to undergo about 8 to 14 days of daily gonadotropin hormone injections.
Oh, right, because in a natural cycle, the body usually only selects and matures one single egg, right? So these daily injections they're flooding the system with gonadotrophins to override that natural limit.
Exactly. You are forcing the ovaries to mature a whole cohort of eggs simultaneously. You're basically maximizing the harvest.
That makes sense.
Yeah, and once those eggs reach the right stage of development, they're surgically retrieved. From there, the patient can choose to fertilize them to create embryos, or just freeze the unfertilized eggs themselves. Both of those are stored in liquid nitrogen at minus 196 degrees Celsius.
Which is incredibly cold.
Oh, it's extreme. But freezing a human cell, particularly an unfertilized egg, is historically one of the most difficult challenges in all of cryobiology.
I read about this. It's because an egg is the largest cell in the human body, right? Which means it holds a massive amount of water.
Precisely.
Yeah.
And what happens when water freezes?
It expands. Like if you think about trying to freeze a delicate piece of fruit, right? Or putting a plastic ice cube tray in the freezer, the water expands as it crystallizes into ice. It physically pushes outward.
Yeah, and if that happens inside a human cell, those ice crystals essentially act like tiny microscopic daggers. They just tear the cellular membrane to shreds.
Yikes. So when you thaw it out,
When you eventually thaw that cell, it's just non-viable debris. That ice crystal problem stalled egg freezing for decades. But the breakthrough that shifted this from experimental to standard practice is a specific technology called vitrification.
Vitrification.
Right.
And it's not just freezing, is it? It's an entirely different physical process. It's like the difference between making cloudy, cracked ice cubes and forging perfectly clear glass.
That is the exact mechanism. Vitrification is ultra-rapid cooling. So instead of dropping the temperature gradually, the cells are first bathed in high concentrations of cryoprotectants.
Like an antifreeze.
Exactly. You can think of them as a biological antifreeze that actively draws water out of the cell and replaces it with this protective fluid. Then the cell is plunged directly into liquid nitrogen.
So the temperature drop is just so aggressive and instantaneous that the remaining water molecules literally do not have the time to organize themselves into an ice crystal lattice.
Exactly. They just stop moving. The cell enters a glass-like state, entirely bypassing the whole crystallization phase. It instantly pauses biological time. The cellular structure remains perfectly intact, holding its viability for years.
Wow, and the ASRM guidelines clearly state the data backs this up. Like, embryo freezing has been standard for about 30 years, but vitrification really leveled the playing field for unfertilized eggs.
It did. It's highly efficient now.
Which, feels like a massive psychological shift for patients, too. It means a young woman facing a terrifying diagnosis doesn't have to scramble to find a sperm donor or rely on a partner to preserve her fertility. She has independent control over her own genetics.
Yeah, it provides complete reproductive autonomy, but as we noted, it requires a 14-day delay to oncology treatment.
Right. The runway.
Yeah, and if you're reading through the pediatric data or the hematology protocols, you immediately see the limitation there. What if the patient has a highly aggressive leukemia and chemotherapy needs to start in, 48 hours?
Or what if the patient is a prepubertal child whose body doesn't even have a mature hormonal cycle to stimulate yet?
Exactly. Standard vitrification is completely off the table then. The biological machinery just isn't there yet, or there simply isn't time to use it.
And that leads us to the surgical alternative, which involves removing the raw material itself, right? Ovarian tissue cryopreservation, or OTC.
Yeah, OTC represents a massive surgical leap. Instead of trying to force eggs to mature inside the body over 2 weeks, surgeons use laparoscopy, which is minimally invasive keyhole surgery, to extract a piece of the ovarian cortex. Or, in some cases, they remove an entire ovary.
And they specifically target the cortex, right? Like the outer shell of the ovary. Because that is where the vast majority of those dormant primordial follicles actually live.
Exactly.
It's basically like skimming the topsoil where all the seeds are planted.
That's a great way to put it. You remove that highly concentrated tissue, process it into small strips, and freeze it. And while slow freezing was the historical norm here, vitrification is rapidly becoming the standard for tissue as well.
Oh, that makes sense.
Yeah, so the tissue goes into the liquid nitrogen, and the patient can literally be wheeled into chemotherapy the very next day.
That is incredible. But the real mechanical marvel here is what happens years later, right? When the patient is cured and ready to conceive, you have this strip of frozen tissue packed with immature eggs. How do you get them to mature and release without the structure of the original organ?
Right, well, you have to transplant the tissue back into the patient's body so it can re-engage with their endocrine system. And there are 2 primary reimplantation methods.
Okay.
The most successful is orthotopic transplantation. This means placing the tissue back into its natural environment in the pelvis. So surgeons will graft the thawed tissue onto the remaining ovary or even into a small pocket they create in the ovarian fossa, the pelvic cavity.
Wait, if you just stitch a piece of tissue onto the pelvic wall, how does it survive? It needs a blood supply, right? Or it'll just necrose and die.
You'd think so, but the human body's capacity for angiogenesis, the creation of new blood vessels, is just remarkable. Within a few days of the graft, the surrounding healthy tissue begins extending microscopic blood vessels right into the thawed ovarian strip.
Oh, wow. So it literally hooks the plumbing back up itself.
Exactly. And once revascularized, the tissue starts responding to the brain's hormonal signals again. Usually around 19 weeks post-transplant, the tissue resumes normal ovarian function. It produces hormones and follicles begin to develop.
And because it is orthotopic-like, located right there in the pelvis near the fallopian tubes, natural conception is actually possible. The data in these systematic reviews is wild. Over 189 live births have been recorded worldwide from these frozen tissue grafts.
And that number is constantly growing. But there is a secondary method we should mention, heterotopic transplantation.
Okay, what is that?
This involves placing the tissue entirely outside the pelvis. Surgeons have grafted ovarian tissue into the abdominal wall or even subdermally in the forearm.
Wait, growing an active ovarian follicle in your arm?
Yep.
That sounds like science fiction. But I imagine natural conception is physically impossible that way, so you'd have to use a needle to extract the matured eggs directly from the arm and fertilize them in a lab.
Yes, you would absolutely require IVF to retrieve them. Heterotopic grafts are less common, and they do have lower live birth success rates than orthotopic grafts, but they are easier to monitor via ultrasound. And honestly, they prove that the primordial follicles just need a blood supply and hormonal signals to wake up, completely regardless of geography.
Geography, right?
Yeah.
But here's where it gets really interesting, because geography brings up a massive red flag in the clinical guidelines. If a patient is diagnosed with a systemic blood cancer, like leukemia,
Right? It's everywhere.
exactly, those malignant cells circulate everywhere. They infiltrate every tissue in the body. So if you remove a slice of ovarian tissue while the patient has active leukemia, freeze it, wait 10 years until they are totally cured, and then graft that tissue back into their healthy body, aren't you essentially handing the cancer a Trojan horse to re-enter the bloodstream?
That is the single greatest anxiety surrounding ovarian tissue cryopreservation. The risk of reseeding the malignancy is a deeply documented concern. In the case studies we reviewed, researchers detailed a really sobering scenario where they analyzed cryopreserved ovarian tissue and actually found it contaminated with minimal residual chronic myeloid leukemia.
Wow. So the cancer was just lying dormant in the liquid nitrogen right alongside the healthy eggs.
Exactly. Which is why rigorous, non-negotiable safety protocols exist. Before any reimplantation is even considered, the tissue must undergo exhaustive histological assessment, and highly sensitive PCR testing is required.
Polymerase chain reaction, right, to look for the DNA.
Yes, they use PCR to search for the specific genetic footprint of the cancer within the tissue sample, and if they find even a trace, the graft is canceled.
So if a patient has their tissue frozen, but later PCR testing reveals it's contaminated, are those eggs just lost to them forever? Or is there a way to extract the eggs without putting the physical tissue back into the body?
Well, you've just described the holy grail of modern reproductive research, in vitro maturation, or IVM.
Okay.
The goal of IVM is to take that frozen ovarian tissue, thaw it in a laboratory, and coax the dormant primordial follicles to grow into fully mature eggs entirely in a petri dish.
Bypassing the human body entirely.
Yeah.
You mature the egg, extract it, fertilize it, and transfer a clean embryo, entirely eliminating the risk of reseeding malignant cells.
That is the goal, yeah. But replicating the incredibly complex sequential hormonal cascade of the human body inside a static laboratory environment is, well, it's monumentally difficult. As the current guidelines note, live births resulting from the IVM of primordial follicles remain elusive. It's the frontier, but it is not yet the standard of care.
Okay, so we've looked at this systemic rush.
Yeah.
The need to quickly pull cells or tissue out of the body before chemotherapy floods the bloodstream. But the sources also cover targeted localized threats.
Right, pelvic radiation.
Yeah, if a patient requires localized pelvic radiation for, say, a cervical or rectal tumor, the threat is essentially a tightly focused beam of energy. If that's the case, why do we need to remove the tissue at all? Can't we just physically move the ovaries out of the blast zone?
We absolutely can. And it relies on a surgical procedure dating back to the 1950s called ovarian transposition, or oophoropexy. This relies on anatomical mechanics rather than cryobiology. The ovaries are surgically detached from their normal position deep in the pelvic bowl and mobilized high up into the abdomen.
But again, the plumbing issue. You can't just detach an organ and drop it somewhere else. You have to maintain its vascular highway.
Right. The key is the ovarian artery and vein. The surgeons must carefully free the ovary from its surrounding connective tissue while perfectly preserving that main vascular tether. Then, they secure the ovaries to the abdominal wall, typically at least 4 centimeters away from the upper border of the planned radiation field.
The intraoperative tools they use to guarantee this works are fascinating, because if you stretch that vascular tether too much or it gets a kink in it, the blood flow stops and the ovary dies. There was a specific case study in our stack featuring a surgeon, Dr. DeVernardo, that detailed how they verify the plumbing before they close the patient up.
Oh, it is a masterclass in risk mitigation. In that case study, the surgical team utilized indocyanine green.
Which is a dye, right?
Yes, it's a specialized medical dye that binds to proteins in the blood and fluoresces brightly when exposed to near-infrared light.
So once the ovary is pinned to the abdominal wall, they inject the dye into the bloodstream, turn on the specific light, and literally watch the ovary glow to visually prove that arterial blood is still pumping through those stretched vessels.
Exactly. It provides real-time confirmation of tissue perfusion. And once the viability is confirmed, the surgeons do one more crucial thing. They place small metallic clips directly onto the transposed ovaries.
Which sounds a bit rudimentary. Why leave metal clips inside the abdomen? Doesn't that risk internal scarring?
A little, but the benefit of mapping the exact location for the radiation oncologist far outweighs the risk of minor adhesions. Because when the patient goes in for their radiotherapy planning scans, those metallic clips show up brilliantly on the X-ray. The oncology team can clearly identify exactly where the ovaries are pinned and calculate their radiation beam angles to actively avoid them.
It's a brilliant physical workaround. It's almost like if you know a flood is coming to the ground floor of your house, you can't move the entire structure, but you can take your most valuable, irreplaceable heirlooms, the ovaries, and carry them up to the attic until the water recedes.
That's a perfect analogy. And it is an effective shield for the ovaries. Studies show up to 60 to 89% retention of ovarian hormone function post-radiation. However, your flood analogy highlights the severe caveat of this procedure.
Oh.
Yeah, you saved the heirlooms in the attic, but the radiation flood still absolutely decimates the ground floor.
The ground floor being the uterus.
Exactly. The pelvic radiation still heavily damages the uterus. It causes deep tissue fibrosis and basically destroys the vascularity of the endometrial lining. The uterus loses its elasticity and its ability to properly support placental blood flow.
So it becomes structurally inhospitable. Even if the ovaries survive and continue to drop healthy eggs, the patient's physical ability to carry a pregnancy themselves is heavily compromised, meaning they would likely need to rely on a gestational surrogate.
Yes, and we also have to factor in age. The protective effect of transposition is not absolute. One study we looked at noted that 71% of patients over the age of 30 still hit premature menopause despite the transposition, compared to only 26% of patients under 30.
Right, because older ovaries simply have less follicular reserve to begin with, making them more susceptible to even scattered secondary radiation doses. Okay, so surgical relocation works for a directional radiation beam. But that brings us back to the systemic wash of chemotherapy. If you are blasting the entire bloodstream with toxins, you can't hide the ovaries in the attic. The blood goes everywhere. So if physical distance isn't an option, how does the medical field attempt to shield the ovaries in situ-like, right where they are? Is there a chemical shield?
This introduces the pharmacological approach, and it is arguably the most debated intervention in our source stack. We are talking about ovarian suppression using GnRH agonists.
Medications like goserelin or leuprolide, right?
Yes.
But how does a drug protect an organ from chemotherapy? It's not creating a physical barrier.
No, it works by altering the biological state of the target. You have to understand the hypothalamic pituitary ovarian axis. Think of the pituitary gland in your brain as the conductor of an orchestra. It constantly sends hormonal signals down to the ovaries, screaming at them to wake up, recruit follicles, and prepare an egg for ovulation.
And as long as the ovaries are receiving that signal, their cells are highly active, dividing and processing DNA. Which, as we established earlier, makes them the exact type of active cells that chemotherapy agents are designed to seek out and destroy.
Precisely. So GnRH agonists are administered as monthly injections during the chemotherapy protocol. They essentially chemically gag the conductor. By suppressing the pituitary gland, they stop the release of those stimulating hormones.
So the signal drops and the ovaries go dormant. You're putting them to sleep.
Exactly. They are forced into a temporary artificial menopause. The primordial follicles stop maturing. They simulate this prepubertal state. And the theory is that by keeping their heads down and not dividing, the cells are locked down and less vulnerable to the DNA-damaging effects of chemotherapy.
Since chemotherapy attacks rapidly dividing cells, making them invisible, essentially, it makes logical sense. You turn off the lights so the chemo passes right by. But does the data actually support the theory?
It's highly nuanced. The massive Cochrane systematic review, we analyzed pooled data from 12 trials involving over 1,300 women. Their conclusion was that GnRH agonists do show a protective effect.
Okay.
Yeah, patients who received the injections had significantly lower rates of premature ovarian failure and higher rates of resuming their menstrual cycle after chemotherapy concluded.
Well, that sounds like a clear victory. Why is it debated?
Because if we connect this to the bigger picture in reproductive endocrinology, resuming your menstrual cycle is not synonymous with preserving your actual fertility.
Ah, I see.
The debate centers on how we define success. Using the resumption of menses as a surrogate marker for the ability to conceive is controversial. The Cochrane Review explicitly warns that the evidence regarding actual live birth rates remains entirely insufficient.
Okay, I see the distinction. The drug might protect the gross endocrine function of the organ, meaning it can still cycle hormones and produce a period, but it might not be successfully protecting the microscopic viability of the eggs themselves.
Right.
And from a patient perspective, injecting a drug that forces you into menopause while you are actively going through chemotherapy sounds absolutely brutal.
The physical toll is significant. These patients experience the full spectrum of menopausal symptoms on top of their oncology side effects: severe hot flushes, mood changes, vaginal dryness, joint pain. And if the suppression is maintained long-term, there is a real risk of bone density loss.
So you are enduring all of that for a shield that might only protect your hormone cycle, not necessarily your future family.
Which is exactly why the major clinical guidelines emphasize that GnRH agonists should be considered an adjunct therapy. They can be offered to help preserve overall endocrine function, but they should never be offered as a replacement for proven methods like egg, embryo, or tissue cryopreservation, if the patient's goal is strictly genetic fertility.
So what does this all mean? Looking across all of this, if you are a patient or a physician mapping out a care plan, the toolkit is incredibly robust. You can use vitrification to instantly pause biological time for individual cells. You can surgically extract and freeze the ovarian topsoil to buy immediate time. You can fundamentally alter a patient's anatomy to sidestep radiation. And you can chemically gag the brain to force the ovaries into protective hibernation.
It is a stunning display of medical adaptability. But the crucial takeaway from all these guidelines is that there is no universal protocol. Every single decision is deeply personal, heavily reliant on the specific diagnosis, the aggressiveness of the required treatment, and the biological age of the patient. It requires incredibly rapid, tight coordination between the oncology team and the reproductive endocrinologists.
Absolutely. But as we wrap up, I want to pivot to a detail tucked away in the nice interventional procedure overview. Because while all of this is focused on cancer care, the raw mechanics of one of these procedures point to an implication that is almost difficult to wrap your head around.
You're referring to the endocrine data surrounding frozen ovarian tissue grafts.
Yes. The primary goal of grafting that tissue back into a survivor is to restore fertility. But the NICE data clearly states that when the tissue revascularizes, it also restores the body's natural endocrine function. It starts pumping out estrogen and progesterone again. The data shows those grafts function for an average of about 2.5 years before degrading.
Right. It effectively cures the premature, medically induced menopause caused by the chemotherapy.
But if you remove the cancer context entirely, what are the mechanical implications for natural aging? Like, could a perfectly healthy woman in her 20s undergo an elective laparoscopy to remove and freeze a portion of her own youthful, hormone-dense ovarian tissue? She leaves it in liquid nitrogen for 30 years. Then, when she hits her mid-50s and begins to experience natural menopause, surgeons thaw that tissue and graft it back into her body.
Well, the scientific mechanics suggest it would absolutely work. By transplanting your own young, dormant tissue back into your older body, the graft would revascularize and begin producing youthful levels of estrogen and progesterone.
You are essentially creating a biological hormone replacement therapy using your own younger organs.
And the medical implications of that extend far beyond simply delaying hot flashes. Because the loss of estrogen during natural menopause triggers a cascade of age-related health issues. It accelerates bone density loss, leading to osteoporosis. It drastically alters lipid profiles, increasing the risk of cardiovascular disease. It impacts cognitive function and joint health.
So if you can graft young tissue back in and effectively pause the biological clock for a few years at a time, you aren't just treating fertility, you are staving off the fundamental diseases of aging.
It shifts the entire paradigm. The ovary ceases to be purely a reproductive organ and becomes a critical lever for long-term physiological health and longevity. It is one of the most profound ethical and medical frontiers right now, and the foundational science proving it's possible was built entirely by researchers trying to save the fertility of oncology patients.
It's just mind-bending. At the start of this deep dive, we talked about Robert and how a diagnosis feels like your future is being erased. But looking at the sheer ingenuity of this clinical toolkit, it is abundantly clear that medical science refuses to accept that collateral damage. Whether it's freezing time in a drop of liquid nitrogen or rewiring the body's anatomy, the lengths we will go to protect a patient's future are staggering. Thank you for joining us as we explore this incredibly complex intersection of oncology and reproductive science. We encourage you to keep questioning the mechanisms, keep exploring the research, and join us next time.